Good afternoon. And welcome everyone to our special session on COVID-19 and chronic disease, the intersection of medicine and public health. We are so grateful that you were able to join us today, even in this virtual format. For those of you who I've not had the pleasure of meeting, I'm Tonette Crossell-Wood. I am a preventive medicine specialist by training, a professor of medicine in the School of Medicine, professor of epidemiology in the School of Public Health. I serve as associate provost for the health sciences, but most relevant today, I'm the associate dean for the MD MPH program. Today's event is part of Tulane's 50th anniversary celebration of the MD MPH program, one of the oldest and largest programs of its kind. Tulane really is honored to be part of training the next generation of physician leaders who really do practice at the intersection or the crossroads of medicine and public health by having the skills and the tools and resources to do so. Since 1971, when the program was officially established, Tulane has graduated over 1,000 physicians from the School of Medicine that also had a formal public health training and a combined degree from the School of Public Health and Tropical Medicine. We're very grateful to our alumni and other supporters who have provided financial support and scholarships and travel grants for our students, helping them to achieve their professional and personal goals. You will be pleased to know that our graduates have accomplished many things, and many of whom are going to be featured today in the panel that have focused on areas including but not limited to tropical diseases, the obesity and chronic disease epidemic, the opioid crisis, and now COVID-19. Many of you today who are attending have actually shared your experiences, how the combined training has advanced your engagement in global health, in clinical medicine, in environmental exposures, as well as health policy management and community health. With today's topic on COVID-19 and chronic disease, we will explore together this intersection of medicine and public health and the scientific and population health foundation that links these disciplines. We all know that the 3 leading causes of death in the US have been consistently reported over recent years to be heart disease, cancer, and third being unintentional injuries. Those in public health and preventive medicine have linked these death rates to what they call the real causes of death that are associated with smoking, physical inactivity, and unhealthy diets, all of which can be adversely impacted by social determinants of health and can lead to health disparities. With the COVID-19 pandemic, the leading causes of death have shifted. They include now heart disease still number 1, cancer still number 2, but now COVID-19 as the number 3 leading causes of death in the US. It is well established that those who are dying with COVID-19 have a high prevalence of chronic diseases such as hypertension and diabetes. And these key factors are contributing to low health resilience and as in responding to disasters and the widening of our health disparities. With disruption that we learned after experiencing Hurricane Katrina, we know that disasters can have a long-term effect. And so we anticipate that COVID-19 will also have a long tail. So understanding how chronic diseases impact health resilience may provide insights on how to best prepare our communities to not only respond to the current pandemic, to be more resilient for what will come in the future. Our speakers today will share their key insights into the interface of COVID-19 and chronic disease. Our first speaker, Dr. Lydia Bozzano, is professor of epidemiology and also of medicine at Tulane. An NIH-funded investigator with over 100 publications, she serves as chair and medical director of the internationally acclaimed Bogalusa Heart Study. Her research focuses on cardiovascular disease with an emphasis on the role of diet, obesity, lipids, and glucose in the development of vascular disease over the life course. Our second speaker is Dr. Jerry Zevotra. He's from the class of 2013. He's a professor of pulmonary and critical care medicine in the School of Medicine and currently a practicing pulmonary and critical care physician providing important services at the front lines of COVID-19, not only at Tulane, but also at UMC. He's an NIH-funded Birch Scholar and is actively engaged in research looking at chronic, communicable and non-communicable lung disease in local and global settings. And he has certainly been on the front lines with COVID-19 in New Orleans and disseminating his knowledge through publications to inform the field about this new pandemic. Soon to be Dr. Alex Razavi for the class of 2021 is an MD MPH candidate who transitioned to the MD PhD in epidemiology. He'll be graduating in May. His work focuses on atherosclerotic cardiovascular disease prevention, and he has been researching the impact of chronic disease on clinical outcomes from patients who have been infected with COVID-19. He successfully recently matched into the competitive internal medicine program at Emory, and this hopefully will support his career aspirations of becoming a preventive cardiologist. Next, Dr. Angelina Yogi is a professor of internal medicine and pediatrics here at Tulane and an active volunteer for Physicians in Human Rights and the Resident Initiative in Global Health. She also directs the formerly incarcerated Transitions Clinic program, which links people transitioning out of incarceration with medical care and reentry services into the community. As a hospitalist at UMC, she is directly caring for patients during the COVID-19 crisis. And last but certainly not least, Dr. Joe Cantor from the class of 2010. He is a state health officer and medical director for the Louisiana Department of Health. A practicing and board certified emergency physician, Dr. Cantor cares for the diverse spectrum of patients in the New Orleans area, including some of the most vulnerable in our community. During the pandemic and as a public health and clinical leader, he has continued his commitment, expanding access to patient-centered care, promoting health equity, and creating efficiencies in systems of health while protecting our vulnerable populations during this incredible pandemic. So our first speaker will be Dr. Lydia Bozzano. Thank you for being here. The information about our CME is now showing on the screen. Please know that it's being offered. The disclosures of our faculty are listed on the screen before you. And now we'll begin with our first presentation. Thank you for joining us. Dr. Bozzano?
All right, thank you for having me. So most of my work focuses on chronic disease and cardiovascular disease and its risk factors in particular. So chronic disease is really common in the US. 6 in 10 adults have a chronic disease of some sort, and then 4 in 10 have 2 or more chronic diseases. And many of these include hyperlipidemia and hypertension. Those are some of the more common ones that are also risk factors for heart disease. So I think many of you will recall that New Orleans has lots of unique traditions and festivals. There's Mardi Gras, there are nights out on the town, there are po' boys, there are beignets, and lots of food and music and other sorts of entertainments. And some of those traditions they're wonderful, but they're also perhaps not as great for our health in terms of chronic diseases. Most New Orleanians spend some time eating seafood, lots of it fried. And we'll go ahead and take a look at a story from New Orleans.
Hi, I'm James Clessy, founder of Clessy's Restaurant and Catering here in New Orleans, Louisiana. We operate a seafood restaurant that's in the middle of a neighborhood for the past 5 years. We operate a restaurant with my brother and my sister, and the tradition I carry on is we supply good times, good food for good people right here in the neighborhood. And we do it the same way people in South Louisiana have been doing it for generations and generations. So today we're gonna boil some crabs. These are blue crabs, Louisiana blue crabs. and we're going to bowl them up for you today, right now.
And that story actually came from American Portraits, which is a PBS series. There's another New Orleans story as well.
My name is D'Artagnan, but sanitation worker for 4 years. I am a native of New Orleans. This is the Mrs. This is the Queen Bee right here.
I love these down home stories because they really are. They feel very New Orleans, and I'm a native myself. So, but some of the things that we do and the environment around us can be less than great for health resilience. There is more tobacco smoking that occurs in Louisiana and Mississippi, Alabama, as you can see on the map there, than occurs in other parts of the US. There's lots of gatherings with fried foods and a little bit less exercise than perhaps there should be. And so some of this is because of our weather, for sure. It makes it difficult to get out and do much exercise if the heat index is greater than 100 in the summertime. And if anybody has spent any time on the roads in New Orleans, they'll also know that there are some unique issues there. There's also crime and some other things that may keep people from being physically active in their neighborhood and or outdoors during the year. So what you can see in the map there is that we are in an area where more than 30% of people are physically inactive. And then, of course, you can see the foods on the side here. This is actually the prevalence of self-reported obesity. Many of you have probably seen a slide set like this that goes through that prevalence. This is going from 2011 to 2019, and you could see even in that last slide in 2019, we were at over 35% in obesity. This is not overweight, this is BMI over 30 obesity. And because of some of these risk factors and the number of chronic diseases that we are subject to, life expectancy in Louisiana and along that Mississippi River Valley, the southern portion of that Mississippi River Valley, is a little bit less than it is in the rest of the nation. So in much of the nation, the average life expectancy at birth is around 78, and in Louisiana, it's closer to 75. We also have more diabetes. Now, this is diabetes mortality, which it looks like we're not doing too bad with the diabetes mortality as compared to some of our neighboring states. Not that that is the bar that we should compare ourselves to, but mortality-wise, we're doing okay. However, the prevalence of diabetes, because of the risk factors, has been increasing over time. And this is heart disease mortality. So many of those things that I showed you before, in fact, all of them were risk factors for heart disease. And so as you can see here, we are in the highest range for heart disease mortality. And not to mention other chronic diseases, the second most common cause of death, cancer. And you can see that we are higher for age standardized mortality rates from cancer as well. And I like this because it kind of puts all those risk factors together, lots of them, which are also risk factors for COVID. These are different chronic diseases. And this is a heat map. So the only one in which we are doing well compared to many of the other states, perhaps, is Alzheimer's disease and other dementias. And that is significantly lower than the US rate overall. However, that could be because many of our folks are not reaching or dying of other things earlier, potentially. So we have lots of ischemic heart disease, cancers, road injuries, self-harm, cerebrovascular disease, et cetera, compared to other states and the national average. And then this final map is multiple chronic conditions. So this map shows you where in the US, which states have the most multiple chronic conditions. And I mentioned that 40% of Americans have multiple chronic conditions, 60% have at least one chronic condition. And so here in Louisiana, we are at greater than or equal to 12.2% in 2014. And then finally, this really sets us up for potentially more severe COVID-19 illness. So if you look at this map, it has where those chronic disease risk factors are particularly high. And those things set us up for worse outcomes with COVID-19. So in summary, Louisiana and just the Mississippi Delta region overall has a high prevalence of chronic comorbid conditions, and it really lets us be at a higher risk for more severe diseases, especially COVID in particular. And this means that more people are likely to require hospitalization, more ICU care may be necessary, and more mechanical ventilation.
Okay, well, thank you so much, Dr. Bozzano. Very important information. We look forward now to the presentation looking at COVID-19 and chronic disease, the inpatient crisis by Dr. Zevotra.
All right, thank you, Dr. Crosswood. So as has been pointed out, I'm a pulmonary and critical care physician, class of 2013, practicing here at Tulane. Okay, so the New Orleanian timeline for COVID-19. So on February 25th was Mardi Gras Day last year. On March the 9th, we had our first presumptive positive case at the VA, followed a couple of hours later by our first case at UMC. By March the 10th, 5 more were diagnosed and the St. Patrick's Day parades were canceled. On March 11th, the World Health Organization declared COVID a pandemic. On the 14th, we had our first death here in New Orleans. By the 15th, we had 77 cases and our second death. This is just day by day. On the 16th, we had our third death, and at that point, casinos, bars, movie theaters, and restaurants were closed. By March 29th, this is just 20 days after our first case, we had 1,350 cases and 73 deaths. So I mainly work in the ICU at the University Medical Center, and this is just to show the inpatient census of COVID-19 patients at UMC. And interestingly enough, we have a 20-bed ICU, but if you look at our first wave, the orange is the total number of patients in the medical ICU. We were up to 60. So not only did we use the medical ICU, we took over the trauma ICU, in addition to opening up a third ICU. And at one point, we had upwards of 40 patients intubated who had COVID-19. So it was pretty dire and pretty high numbers here in New Orleans. So as you would have seen in the media, we were an early epicenter of COVID-19. After it hit in Seattle first, we were an early epicenter, and we were in the news pretty significantly very early on. And as I showed, we had pretty high numbers to begin with. So we asked ourselves a question. When we were seeing our patients, there was a certain phenotype of patient that seemed to be very common in the hospitalized patients. So we asked ourselves, is obesity one of the major determinants of hospitalization with COVID-19? And we looked at this and actually published in the Journal of Obesity pretty early on. And what we found was, this was a very early study with 183 hospitalized patients here at Tulane. And determinants of ending up in the medical ICU were increasing age, which we knew about from earlier studies coming out of China, lung disease, hypertension, and also BMI. If you can go back just a little. as you can see, BMI was a pretty strong predictor of ending up in the medical ICU here in hospitalized patients at Tulane. We then looked at it with increasing BMI by 5 and by 10, and we saw an increasing odds ratio of ending up in the ICU as your BMI went up. I would be remiss to talk about the crisis here in New Orleans and publications without talking about the one that came out of Ochsner, where they looked at 3,500, pretty much 3,500 patients who tested positive for COVID-19. And they looked at determinants for hospitalization. And one was race early on, which I'll talk about a little bit later on, but also they looked at Charlson Comorbidity Index, which in essence is a index where the more comorbidities you have, the higher. So for instance, diabetes, hypertension. And they found that with more comorbidities, you were more likely to be hospitalized. And again, also found that obesity was a pretty strong determinant of being hospitalized with COVID-19. So then we then asked ourselves, we were seeing a lot of obese patients, but again, there was a certain phenotype of patients that we were seeing. So we asked ourselves, is it metabolic syndrome that's a major determinant? And metabolic syndrome is any 3 of these 5. So not just central obesity, but also dyslipidemia with hypertriglyceridemia, low HDL, elevated blood pressure, and also an elevated fasting blood glucose. We published on this also, and what we found, and to just outline what we're looking at here, the gray horizontal line is an odds ratio of 1. So if you're over to the right, there's an increasing odds of any one of these outcomes based on, there's an increasing odds of any one of these outcomes. So we looked at ICU admission, ARDS, which is acute respiratory distress syndrome or severe lung disease from COVID, invasive mechanical ventilation, so ending up on the ventilator, and also in hospital mortality. And what we found across the line was metabolic syndrome as a composite variable was strongly associated with any one of these outcomes, with a stronger association than the individual variables that make it up. So it's unclear if this was additive or a potentiation of these, but there's a potential potentiation of all the components of metabolic syndrome leading to worse outcomes with COVID-19. And then we asked ourselves, are there disparities in people who get hospitalized and in mortality? So this is yet to be published, but to go over it quickly, we found that 86% of the patients who were hospitalized at Tulane at one point were Black American patients. Compare that to just 47% in 2019 of people hospitalized at Tulane were Black. We looked at intubation and mortality risk. We set it up as Black women versus Black men and white women versus white men. And we found that once people were hospitalized, they had similar outcomes. So there was similar mortality and similar intubation risk. This is shown again in the table on the right. And the determinants really were older age, being retired, which is a marker of older age, Medicare, another marker of older age, and increasing comorbidities were associated with being ventilated and dying in the hospital. But socioeconomic status and insurance status really were not at all associated. So once hospitalized, patients did about the same, regardless of socioeconomic status. And then finally, a study that came out of Tulane also looked at, are there disparities in outcomes for men and women? And they did find disparities in outcomes for ICU admission. So to orient you just a little, women, there was a difference in the effect of BMI, diabetes, COPD, CKD in outcomes. So women had different outcomes when they had these comorbidities than men did when they were hospitalized with COVID-19. That's for ICU admission. Next slide. For invasive mechanical ventilation. Next slide. And finally, for death. So what are the take-home points? Increasing BMI and obesity are associated with increasing COVID-19 severity and ICU admission. The individual components of metabolic syndrome may have a synergistic effect in worsening COVID-19. Once hospitalized, patients with COVID-19 did similar, regardless of race or socioeconomic status, and COVID-19 in New Orleans disproportionately affected Black women with disparate outcomes by sex.
Thank you very much, Dr. Zevotra. Excellent presentation, and thanks for sharing your personal and professional insights. Our next speaker is soon to be Dr. Alex Razavi, talking about atherosclerotic cardiovascular disease and the COVID-19 lockdown.
Thanks, Dr. Crossellwood, and thank you to all the attendees for being here for the presentation. So I just first want to start talking off broadly about cardiovascular disease prevention and the implications of COVID-19 and how medicine and public health have traditionally separated the prevention and treatment of communicable and non-communicable diseases. However, the COVID-19 pandemic and broader public health disasters such as Hurricane Katrina have actually challenged this paradigm, particularly in the setting of CVD. For example, we know that 1 decade after Hurricane Katrina, the incidence of acute myocardial infarction increased by about 4-fold compared to 1 to 2 years prior to the storm. And we know that individuals with prevalent CVD and or risk factors such as obesity and hypertension who contract COVID have a worse prognosis. And I think these observations suggest that an integrated approach to prevention is necessary. And the goal of my short talk today was to talk about how our strategies aimed at mitigating the spread of COVID that have been highly effective, and particularly lockdowns, and how they influence lifestyle behaviors and also primary care in the general population. So lockdown is a restriction policy for people to stay where they are, usually due to a specific risk to themselves or others. And in the setting of COVID-19, the first lockdown was implemented in January 2020 in Wuhan. And then moving to the United States, California was the first state to issue a statewide lockdown just over about 1 year ago today on March 19th, 2020. So I think just in terms of looking at the effect of these lockdowns on lifestyle habits in the setting of CVD prevention, I think it's helpful to focus on 2 main categories on how individuals are staying at home, which is going to limit their ability to exercise outdoors and access gyms, which are closed, but also disruption of normal work routines for individuals who may walk to work, bike to work, and now they're working from home, so they're significantly moving less. And then secondly, the stockpiling of food or changes in the way we purchase foods at the grocery store, reducing trips to the grocery store to reduce exposure, all of which may change dietary habits. And we've seen these patterns happen, for example, going back to the Hurricane Katrina example. And I think presenting these data and moving forward, how we can assess these outcomes in the long term to prevent CVD. So here's a slide showing the association of the lockdown with physical activity and weight gain outcomes. If we first focus on the slide on the left, we can see a change from baseline step count on the y-axis across time. And right around where the majority of lockdowns happen in the United States, we can see about a 20 to 40% drop in mean daily step count across a wide variety of cities in the US. And there, I think the notable thing to see here is that there's a consistent drop in step count regardless of the region of the country that people were in. And then moving to the right, we can see mean weight change from baseline weight. In regards to a shelter-in-place protocol, again, this study was conducted in the US using Bluetooth scales, which people were using at home. And this study found that there was an average 1.5 pound weight gain over this 28 days. And we can quickly see how this can become additive across the months of the pandemic and as we move forward, and how this may adversely affect cardiovascular health in the United States. And then moving to dietary behaviors and their changes, a majority of this data has come from overseas, in particular Italy. Looking at the graph on the left, we can see just based on the stars on how the percent of the population reporting an increased intake of such items, legumes, non-perishable items, common that can be stored, eggs, which are easy to cook. And then down below, you can see several comfort foods such as homemade sweets, pizza, and cereals, which can be stored for a long duration of time, may be high in added fats and sugars and sodium, which may, again, adversely affect upstream risk factors for cardiovascular disease. And then interestingly, these findings have been somewhat consistent across different studies. Moving to the graph on the right, which shows percent increase in sales again, and this was conducted in Italy, showing on how breads and refined carbohydrates, foods high in flour, are among the highest that increases in sales. Again, though, you can see legumes, which may be cardioprotective, which is something interesting to note, also increased in sales, and then followed by cakes and canned beans, which may be high in sugar and sodium respectively. And in addition to lifestyle behaviors that have changed over the course of the lockdown has had a substantial effect on our mode and form of primary care delivery in the United States. This is a graph table from a recent JAMA report looking at the change and trends in primary care prior and during the lockdown. Prior to the lockdown in years 2018 to 2019, office-based visits contributed to about 93 to 94% of all primary care visits. But if we can see all the way on the far right, in Q2 of 2020, this number dropped to 59%, a substantial drop off. And then looking at telemedicine, likewise, prior to the pandemic, contributed about 1 to 2% of all primary care visits, but then jumps up to 35% in the Q2 of 2020. And I think this is something that we should be proud of, on how we were rapidly able to improve telehealth and telemedicine during adverse times. But as we see in the next slide, that regardless of office-based visits or telemedicine visits, despite an increase in trying to obtain people remotely, that ASCVD risk factor assessment has actually decreased during the pandemic. For example, blood pressure, there's a 50% reduction in blood pressure assessment during the pandemic, Q2 of 2020 compared to 2018 to 2019. And cholesterol assessment as well dropped by about more than 1/3. So even though we've increased telehealth services in an effort to reach individuals and assess primary care, this telemedicine adoption has not had a one-to-one correlation with ASCVD risk factor testing in the population, which is going to be important to consider in terms of preventing primary events. So I think take-home points, the COVID-19 pandemic and lockdown measures have led to a reduction in physical activity and a shift in dietary behaviors and habits towards more non-perishable or hygienic foods, which may or may not be associated with an increased risk for ASCVD. If we can improve our public health messaging and gear individuals towards fruits and vegetables, given that there's no foodborne transmission, and if they would like to purchase and stock up on foods, they should stock up on items that have health beneficial properties, including legumes and dry beans. And these changes in physical activity and dietary habits are likely strong determinants for the increase in body weight we saw through those graphs during the lockdown. And outside of lifestyle behaviors, despite an increased utilization of telehealth and primary care, ASCVD risk factor assessment and testing has decreased during the pandemic, suggesting that we need to do more upstream and in our delivery of primary care to promote and maintain cardiovascular health in the US moving forward as we continue through the vaccination phase of this pandemic.
Thank you so much, Alex. This was an excellent presentation and a lot of food for thought, if you will. Our next presenter is Dr. Angelina Yogi, class of 2002.
Great. Thank you so much, Dr. Crosswood, and for everyone for being here. I'm going to talk about a topic that is dear to my heart and a little bit different than what the population we've been discussing. So I'm going to talk about people who've been incarcerated and how COVID has affected them. I want to start off and just look at the numbers of who is incarcerated. So as you can see from this graph, this looks at who's incarcerated from 1920 to 2010. And from 1920 to 1980, the number of people that are incarcerated is relatively stable. And then from 1980 to 2010, and even through 2020, the numbers haven't changed. There's a drastic increase in the number of people who are incarcerated. And this corresponds really to the war on drugs. And in fact, if you look at 1980, the total number of people who were incarcerated in the United States was about 500,000. If you look at 2010, the number of people who are incarcerated just for drug-related crimes is about 500,000. We've been talking about COVID and disparities with COVID, and I wanted to point out the disparities, and particularly racial disparities in incarceration. So this is looking at the lifetime likelihood of imprisonment. And if you can see, the Black men, if you're a Black man in the United States, you have 1 in 3 chance of being incarcerated or justice involved in your life, compared to 1 in 9 if you're for all men. So that's 3 times higher. Latino men is 1 in 6, Black women is 1 in 18, compared to 1 in 56 for all women. And then looking at what has happened in our jails and prisons with COVID-19. So on the left, this graph on the left is looking at the number of people with COVID-19 infections per 100,000. And as you can see, in the US population, there has been a substantial increase in incarcerated populations being infected with COVID-19, 6 times higher by the summer of last year for people who are incarcerated. And that number continues to grow. And in some states, it's as high as 8 times higher. And then the graph on the right shows that it's not only people who are the inmates that are affected, but also correctional staff. And I think that's really important to remember, because correctional staff at the end of their shift, they're going back home, they're going back into their communities. And so this risk of transmission back and forth between prisons and jails and back into community is very much real. And that, you know, it's important to remember this isn't an isolated event just in carceral settings, but that actually can affect the entire population. And since this webinar is about chronic diseases, wanted to point out that people who are incarcerated have a significantly higher prevalence of chronic disease in general. And so if you look here on the very, very right are the percentages of people in the United States, and the sort of towards the bottom of the table, we have hypertension, diabetes, and heart-related problems. And so going down those, in the US, about 18% of people have hypertension, whereas the incarcerated population, that number is as high as 26%. Same with diabetes, 6.5 in the US population versus 9% for incarcerated populations, 3% for cardiovascular, and up to 10% for those that are incarcerated. And one of the things that wasn't great in a table, and there aren't super great statistics for this, but obesity, since we've been talking a lot about that, about 60% of people who are incarcerated are somewhere on the spectrum between overweight and obese. So I'm going to spend a little bit of time on this on the slide. So these are 2 photos. They're pretty general representations of what prisons look like. The one on the left is a large prison complex, and those sort of rectangular boxes that you see are dorms. So some of them may be solitary, some of them may be death row, and for the most part, they're going to be sort of general population. And in between those, you can see the little white lines, and those are pathways between the dorms. And that's important just so that, you know, we understand that there is oftentimes movement going back and forth between the dorms, movement of inmates, but also movement of correctional staff. And so there are, that can serve as a vector, that can serve as ways of transmission, and it can really affect the entire complex, and particularly with correctional staff. And then the photo on the right is a typical dorm. This is a general population dorm. And I really want to highlight the beds and the bunk beds. And so if you can see, there's really not 6-foot distancing between the bunk beds, either vertically or horizontally. Those beds are oftentimes bolted into the ground, and so you can't move them around. You can't create that space. Capacity of prisons is oftentimes either overcrowded, or even at the height of the pandemic was about 90% at capacity. And so it's really difficult to maintain that social distancing. The other thing I want to point out is at the very end of this picture, you see a door and that door is closed, and you see a lot of windows, but oftentimes those windows don't open. And so it's one large dorm with some fans, but a lot of recirculated air. And as we've understood with this pandemic, and particularly in office spaces, that having good ventilation is one of the ways to prevent the spread, but it's really difficult to have that in a prison setting like this. On the same slide, I do want to talk about a few things that that the prisons did do to curb the spread of COVID pretty early on. One of the very first things that was done was that in-person visits were suspended. This is for family, friends, but also for legal staff and advocates. They also reduced transfers between prisons and between jails and prisons. There was a implementation of quarantine. So if someone in the dorm was to test positive, that entire dorm would get quarantined right away. Kind of coming back to that picture on the left, one would think, well, can't we just quarantine correctional staff as well with the dorm? And while that was attempted, unfortunately, there has been an inadequate number of correctional staff, particularly during this pandemic, because people are afraid of either getting COVID or have actually gotten infected with COVID. And so there just aren't enough staff to be able to quarantine a dorm entirely. One of the other things, and this is based on a CDC recommendation, is for people to sleep head to toe. So because you can't do the 6-foot distancing necessarily between the dorms, one of the recommendations was one sleeps, the head is at the head of the bed and the other person has the head at the foot of the bed, and try to maintain a 6-foot distance that way. And then the other thing they did was to eliminate copays so that people who are symptomatic wouldn't have a barrier for seeking care. However, staying on the slide, there's some things that I think that could have been done early on, and hopefully will, with the next surge, can be implemented. One is to do an early sort of contact tracing. And so people who were infected in dorms were quarantined together, but there was not a robust contact tracing and testing for people who had been in close contact with those people. Also, early systematic testing of people, which is happening now, but hopefully next time we'll have the supplies available to be able to do that early on. And then also providing PPEs and making sure that there's enforcement of PPEs. And the biggest one that we have found is reduction of the patient population or the prison population. And so I want to really highlight this a little bit. And so there was a report that came out in the JAMA Health Forum that really said that national academies are urging that the inmate population in jails and prisons be reduced to curtail COVID-19. And this is important because, as we said, it's been really difficult to maintain all of the social distancing practices, to quarantine, to isolate, to keep correctional staff from being able to go back and forth between dorms and back to their communities. And so one of the best ways in order to decrease the transmission is to just not have that many people. So not have overcrowding, and to decrease the number of people that are incarcerated. And so what do we do to sort of help with this situation? We partnered with a legal organization called the Promise of Justice Initiative, who works a lot with people who are incarcerated, advocating for health needs. And we created these medical legal partnerships. This was with Tulane Medical School students, Tulane Public Health students, Tulane residents, and Tulane faculty, and then law students from the different law schools in New Orleans partnered together to write letters on behalf of these high-risk patients with multiple comorbidities, and really advocated for their release. We sent over 50 letters. And the next step that we're now looking at is to propose a legislative study to look at compassionate release programs in Louisiana, really to hope that we are able to prevent unnecessary deaths in our incarcerated population. And so the take-home points really are, there's a higher risk of COVID-19 infections and deaths amongst incarcerated populations. There's profound racial disparities in incarcerated populations, just as we've seen throughout COVID-19. Incarcerated people are more likely to have chronic diseases and have multiple chronic diseases that are a risk for severe COVID-19, and that reducing the patient population or the prison population through compassionate release or medical parole can be a public health measure during COVID.
Thank you so much, Dr. Yogi. And now we're going to wrap it up with Dr. Joe Cantor, who is a class of 2010 and our Louisiana State Health Department health officer.
Thank you, Dr. Krause-Wood. It's nice to be with you. Thanks to your team as well. I'm a Tulane MD, MPH grad, and it served me very well. So I'm very appreciative of what I've gained from Tulane. I wanted to talk, I know we're a little short on time, so I'll be brief. I wanted to talk a little bit, dovetailing on what Dr. Yogi covered. And I want to talk specifically about poverty as a chronic disease as it relates to COVID, and inequity and racial disparities as a chronic disease as it relates to COVID. You look at the mortality experience in Louisiana, which has been considerable and is not done with. We have 10,264 deaths so far and counting. Disparities and poverty play a very, very big role in it, and it's changed over time, and that's worth getting into a little bit more. You know, our outbreak has been trimodal in Louisiana. We had a surge, as was pointed out early on by Dr. Zevotra, March and April, one of the first ones in the country, just behind Seattle, really. We had a surge in the middle of the summer, July and August, and then we had a surge this past winter in December and January. I caught Dr. Yogi saying something about preventing it on our next surge, and I hope we prevent our next surge. We have an opportunity to, but I am worried about the variants. The first surge that we had back in March and April really was focused in the greater New Orleans area. That was clearly the epicenter. The two surges after that, the summer surge and then the Christmas and New Year's surge, were statewide surges, corner to corner, all 64 parishes. That first surge in March and April, a year ago, in the New Orleans area, it's easy to forget now, but listening to Dr. Zevotra explain some of the experiences in the ICU back then, and brought back a lot of memories. For 2 weeks in the middle of March, we were the fastest growing outbreak to date in the world at that point in time. Faster than Italy, faster than South Korea, faster even than the Wuhan region of China. Things were growing very, very, very quickly. If you look at mortality in COVID by race, at today's date, 38% of deaths have been in Black Louisianans, despite representing somewhere between 32 and 33% of the population. That disparity has actually gotten better over time. And when you graph out mortality incidence by rate over time, you see big disparities in the beginning. And by August or September of 2020, the rates of death in Black and white Louisianans pretty much equal and carry on equal through that date until now. And you see almost the same thing with cases. Big disparities in case rates early on between Black and white Louisianans. And then around September, August or September or so, they meet head to head and have been almost even as a rate, the percentage of the population since that point. A lot of the disparity mortality happened as a result of that early experience in New Orleans. And looking a little bit closer at that, you know, a few things I think are contributory. There are probably many, many others. Of course, there's a higher burden of chronic disease in New Orleans in particular. There is in Louisiana as a whole. There's certainly a higher rate of exposure for people that live in poverty or close to poverty. You can't isolate or quarantine from your family if you live in a multi-generational household. If you have a job that doesn't afford you the privilege of working remotely, you can't do that. If you rely on public transportation, all those things make the exposure risk much, much more significant in people who are in poverty. And then there's a leading edge effect, which is on the front end of this pandemic, back in March and April, the mortality rates of people who were hospitalized were much higher than they are now for a few reasons. The medical community has learned a lot about how to treat COVID patients. I'm an ER doctor as well, and I can tell you we've changed practice quite considerably since those first few weeks. We've learned to delay intubation until the last possible moment. We're making much greater use of non-invasive ventilation strategies. People are being treated more along the lines of an ARDSNet protocol. There's steroids, all types of clinical knowledge and innovations we feel more comfortable with now that we did not in the very beginning because COVID was new. It was brand new. We didn't have enough PPE. We didn't have enough supplies. We came very close to running out of ventilators. We had to put some patients in a makeshift hospital in the convention center. Hospitals were busy. Clinical teams were tired. And the mortality rate increased as a result of that. NYU just did a nice study, and they showed their mortality rate has gone from 26% in March down to 7.6% a few months later in the year. We saw a similar thing here. So folks that were diagnosed with COVID, got sick, got hospitalized, had worse outcomes on that leading edge. And that's one of the reasons why we initially saw such a big racial disparities, because you compound the chronic disease burden with the increased exposure risk, with the increased mortality that we saw earlier on for all of those reasons. And a lot of people in New Orleans got caught in that. Overarching lesson that I think a lot of folks have taken away, and I certainly have, is that vulnerable people are vulnerable, regardless of the emergency. We've gotten really experienced with the emergencies in Louisiana, from weather events to you name it. It doesn't matter what the emergency is, vulnerable people are vulnerable. That was the experience of Katrina. It was the experience of numerous events since then, certainly the hurricanes of this past year, and it's been the experience of COVID. Vulnerable people are vulnerable. So really the onus is on us to treat that vulnerability. My hope, the hope of a lot of people in the health department right now, is that we can use the experience of COVID to really address poverty, inequities, and disparities going forward in a way that we just have not been able to do. I'll tell you, we get asked a lot about the state health rankings. Why is Louisiana 50th or 49th? We're always at the bottom, and people want to know why. If you look at the 10 measures that put us at the bottom of the health rankings, the 10 most impactful measures, and state health rankings do a nice job of categorizing those out. 5 of the largest 10 measures that put us at the bottom are not truly health measures, or economic measures. Economic hardship, income inequality, food insecurity, mental distress, adverse childhood experiences. 5 out of 10 are really issues related to poverty and inequity. We need to put more focus into that, and we really hope that the experience of COVID is going to make it hopefully less easy to ignore that. We certainly know that inequities, disparities, particularly in Louisiana, existed long before COVID. It's that much harder to ignore them now. Going forward, I want to talk a little bit about structurally what can the health department do, what can government do. A year and a half before COVID started, the health department launched an Office of Health Equity, which is it's a necessary but insufficient step to really address these type of issues, but it does add some institutional framework. Early on in COVID, the governor launched a dedicated health equity task force for COVID, which was one of the first in the country. And on one hand, it's just a task force, but it has been quite effective at driving policy within state government. They've had a good voice, and they've actually had some great impact on policy and where resources have gone during the pandemic. Looking forward, health department is on the verge of starting a very large strategic planning process. We call it a business plan, but essentially it's a 5-year strategic planning initiative. And there's been a lot of discussion about why do that now during the pandemic. The pandemic's not even over. People are tired. Why go through that process now? But in retrospection, we found it all the more important to do it now because the issues that were uncovered, I mean, they were there before, but really impossible to ignore because of COVID. Issues of racial disparity, inequity, inequities in chronic disease burden that really have driven some of the more regrettable outcomes of COVID. Those are the issues that we need government agencies like the Department of Health to be focused on. And so in that respect, there's a lot of power in actually doing this strategic planning process on our part during COVID, because it's impossible to ignore those issues. And we think we're going to get much more buy-in from legislature and other stakeholders because it really is that much harder to turn a blind eye when COVID is still going on with us. So we're using the experience to try and gain leverage to make structural change in these areas, at least on the governmental side going forward. We'll see how it goes, but we're very committed to this right now. I will say, I think it's on all of us to hold government officials, elected leaders, responsible for this. And I think people in the academic world and the clinical world have a job to do to hold us in the health department, hold the governor, hold everyone in state government responsible for addressing these issues after COVID abates. COVID will go away, inequities and poverty, all the other issues that we talked about, mass incarceration, they're not going to go away. And it's going to be really up to us that care about that to hold everyone else accountable. So I'll take a pause there, Dr. Council-Wood, and turn it back over to you.
Thank you so much, Dr. Cantor. This is an excellent overview, and thank you for sharing your experiences in Louisiana. We have a few minutes for questions, so we're going to go ahead and open it up to our panel. We are getting close to the time. We are getting close to the time to wrap up this session, but we had a question about how can the public health system and infrastructure address not only the problems that we're having with COVID-19, but the other ongoing chronic conditions that we're plagued with, as well as other communicable diseases like HIV. What is the public health system doing to make sure that we're not losing sight of these issues as well?
Let me take a stab at that. I mean, it starts with funding the system appropriately. We've been the victim of just repeated cuts. I mean, in Louisiana, the way the budget is set up, when you have to make a cut, which happens all the time, you really have education and healthcare at the table to cut, and that ends up being it. And the health department really, during the general administration was just gutted completely, and has been built up methodically during this governor, but it takes time to do that. So, starting with the pandemic, we came in handicapped. I mean, the department was in the process of rebuilding, and a lot of institutional knowledge has been lost. The manpower of the department was cut. So you have to fund these agencies appropriately. I think that's the first thing. The second thing is we have a structural advantage with our health department in that we have, it's what would be referred to as a mega department. We have Office of Public Health, Office of Behavioral Health, and the Medicaid program all under the same department. Not every state has that. Not every state has that, and it's a lever. It's a tool you can use to make sure your goals span across those different avenues if you pull it. And historically, we've been too siloed in our own department to really make use of that. So that looking forward, I think that's a real big tool because you can't leave the payer side out of it. We can't leave Medicaid out of it. If we want to make inroads into chronic disease, we have to make sure that the healthcare provision for people that rely on Medicaid, for example, are aligned with that, and the incentives.
Okay, no, thank you. That great answer. A lot of what was presented today, and we probably have time for one more question, we'll have to address the others perhaps offline, is that healthy lifestyles or unhealthy lifestyles leading to obesity and chronic disease and the other have a significant impact on COVID-19 and our resilience. What can we do to actually address this and actually make Louisiana and other states a healthier place? That might be to Dr. Bozzano or soon to be Dr. Razavi.
I think there are a lot of things that are happening and that continue to happen. It's a slow process to improve chronic conditions, just like it's a slow process to have them increase in many ways. So, more exercise, better diet, all of those things have been in the news lately, and especially obesity because of the vulnerability to COVID. So I'm hoping that things will move in a better direction for those reasons.
And yeah, I think just adding upon what Dr. Bozzano said, I think integration of medicine and public health systems is necessary and could improve. For example, I think giving everyone availability and access to a gym, if in the setting of another pandemic, maybe we can help subsidize at-home exercise equipment, for example, and in terms of assessing lifestyle over the life course and risk factors, we can go and do more in-home visits to measure these risk factors as well, as opposed to bringing people into clinics if there's potential exposure in the future.
Okay, thank you. And I know for our participants today, we had many more questions. I wish we had time to get to them, but I know that we're at the top of the hour. We will share these questions with our panelists, and they can get back to you with responses separately. And we thank you for joining us today. We appreciate your time and attention. Please don't forget to fill out the CME activities if you're looking for that credit for attending today's session. Many thanks to our panelists, outstanding job today, to our participants who came in and listened and provided interesting questions for us to ponder, as well as the program staff who helped coordinate this session today and providing an opportunity for us to connect. So wishing you all a very safe and healthy rest of 2021, and we look forward to seeing you at future events celebrating the 50th anniversary of the MD-MPH program. Thank you and have a wonderful day.